Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Kevin Astle presents a case-based discussion on providing options for PrEP re-engagement as a strategy to support PrEP persistence and re-engagement. Dr. Astle is an assistant professor of pharmacotherapeutics and clinical research at University of South Florida in Tampa, Florida. For the full online educational program, Staying on Track, Strategies to Support PrEP Persistence and Re-engagement, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Astle has to say.
We're going to be following a patient case throughout and discussing different options for this patient. So we have a 25-year-old cisgender man who has sex with men. He's been prescribed emtricitabine and TDF daily for PrEP about a year ago, but he never really followed up after the first 90 days prescription. So we're not really sure what he's been doing for prevention since then. He presents to an urgent care clinic on Monday and reports having condomless sex with a partner of unknown HIV status the previous Saturday night. He states that at this time that he stopped PrEP after his initial prescription ran out, and his primary reason for doing that was concerns about long-term safety and adverse events, and he didn't really feel like it was worth it for his risk. We have some of his different labs that were done at this urgent care visit. So he has an HIV antibody antigen combo test that was non-reactive, and then subsequent HIV-1 RNA viral load that was not detected. For his hepatitis B status, he's currently negative. We don't have any vaccination status for him currently, but we do not have any signs of an ongoing infection. And same for hepatitis C. His serum creatinine is 0.78 milligrams per deciliter. So we can extrapolate he has pretty good renal function here. His liver function tests are all within normal limits, and same with the cholesterol. And then his BMI is 28 kilograms, so a little overweight, but overall healthy patient. Minimal concerns at baseline here. So following our algorithm for determining what route to take for patients when deciding whether to start PEP or not following a potential exposure, first want to determine if there's any substantial risk for HIV acquisition, and if there is, when that exposure was. So for this case, the exposure occurred Saturday night, and the patient is now presenting on Monday morning. So we're within that 72-hour time window, which is ideal for starting PEP. From there, we would need to know if the patient, if the contact was a known exposure or an unknown exposure based on that person's HIV status. And in this case, we have an unknown HIV status. So we really want to follow a case-by-case determination. So when doing that, we really want to think about different factors like our risk and benefits of treatment. So what are our side effects and adverse effects we're worried about, and how does that line up with our patient? And thinking about that course of treatment, how would that affect the patient? And then our benefits of preventing HIV acquisition, minimizing our risk of HIV in this patient. And really, most cases, our benefits are going to vastly outweigh our risks, especially this patient having very low risk for any kind of adverse effects that may occur. And even with our treatments we have for PEP that we'll get into, we have very little side effects and adverse effects with those are very well tolerated. So for the vast majority of patients, as long as we're within that 72-hour window, we're going to want to recommend PEP for them. So when looking at our different PEP regimens for our adults and adolescents over 13 years of age, we want our creatinine clearance to be at least 60 milliliters per minute. Our preferred regimen is going to involve emtricitabine and TDF, and in combination with either dolutegravir once daily or waltegravir twice a day. An alternative regimen we can do will still have the emtricitabine and tenofovir disoproxil fumarate, but then we can also consider doing a boosted darunavir once daily to complement that therapy. For PEP, regardless of which regimen we choose, we want to treat for at least 28 days and do following up testing up to 6 months following that exposure, just to ensure there was no seroconversion. So following this patient, and really every patient, anytime we're starting a PEP regimen, we really want to talk about PrEP. This is going to be one of our key opportunities here to really engage patients in PrEP care and maintain that ongoing protection and prevention. But as a big takeaway, we really should be talking about PrEP with any patient that has any kind of potential sexual risk. So any patient that's having any kind of anal or vaginal sex in the previous 6 months, especially if we were concerned about multiple partners or inconsistent condom use or any kind of diagnosis of an STI, we really want to be discussing PrEP with these patients. and making sure that our patients are well equipped. So anytime that I'm giving PEP for a patient, I really want to talk about PrEP options for them. So for our patient who falls under the category of a cisgender man who has sex with men, our FDA-approved treatment options are going to be either daily TDF and emtricitabine or TAF and emtricitabine, as well as our injectable long-acting cabotegravir. And then we also could discuss with the patient, while not approved by the FDA, we have excellent data and guidance from other organizations for on-demand PrEP with emtricitabine and tenofovir disoproxil fumarate, or TDF. And along with PrEP, patients are going to have their concerns. They're either going to hear it from friends or family members. They're going to read information online. And as a provider for PrEP, I always like to hear patients out, reaffirm that it's appropriate they have concerns, and then really address those concerns. So some common issues we might hear about from patients when thinking about our daily oral PrEP options are potential for toxicities and issues and complications with kidneys and bone health, and potential for weight gain. In regards to on-demand PrEP, we hear a lot of concerns about changes in efficacy, maybe from a prescribing perspective, that it might be more difficult to prescribe and monitor for our patients, that we're concerned about patients taking it properly and changes in efficacy based on that. Or patients might not be able to anticipate when they have sex and they're not going to be taking their on-demand PrEP quite early enough. And then with injectable PrEP, some concerns that we hear are that it might be difficult to get, that getting coverage through insurance may be difficult, or some administration concerns for patients that have implants and fillers, particularly our transgender women. These concerns are valid for patients to have, or providers in some regards, but it's also important for us to know what data exists and provide appropriate recommendations for patients with those. So, we'll really get into some of the safety and efficacy data here. So one of the big concerns with using TDF-based products is the changes in kidney function. In a study of 557 men who have sex with men and transgender women receiving daily PrEP with FTC TDF, we did see change in baseline renal function throughout the study and up to 48 weeks, sustaining that. However, when we really look at this change in creatinine clearance and serum creatinine, there's very minimal changes. So while, yes, there were statistically significant changes in our serum creatinine or our creatinine clearance, the clinical implications of these are really minor. So we see a change of about 4 milliliters per minute in our creatinine clearance that we see within 12 weeks and sustained through the 48 weeks. However, for patients with their baseline renal function, that's not going to clinically change their renal function. And it's really more or less an insignificant change there. We also want to look at our bone mineral density, because we do know that the tenofovir disoproxil fumarate can also lead to changes in our bone density. And in this study, which was looking at men who have sex with men and transgender women, we did see some changes in our bone mineral density. However, again, it was a 1% change for patients taking PrEP daily based on adherence. And again, a clinically insignificant change in bone mineral density that occurred during studies. And promisingly enough, we also have data that shows that upon discontinuation of PrEP, we see bone mineral density return. From the sub-study following IPREX that compared the tenofovir disoproxil fumarate and emtricitabine to placebo, upon discontinuation, bone mineral densities returned about the same as they were at baseline within 6 months of discontinuing PrEP. We also have concerns regarding weight change with our oral PrEP options. And we saw in the Discover trial, which looked at daily oral PrEP with tenofovir alafenamide and emtricitabine compared to tenofovir disoproxil fumarate and emtricitabine, we did see some change in weight at baseline, about 1 to nearing 2 kilograms of weight gain over a 2-year period. And it's important here to counsel patients, again, there might be some weight gain, but when we look at our BMI changes, we didn't change within our status really significantly. So again, while statistically significant changes, we did not have clinically significant increases. And that's primarily going to be with our TAF group. With TDF, we did not see statistically significant changes in weight. But we can talk to patients about the potential to gain a kilogram or 2 over a 1 to 2 year period, which is in line with our kind of normal body fluctuation. So again, putting it in perspective for patients. We also want to look at our safety, comparing our daily oral PrEP with FTC TDF to our long-acting cabotegravir injection. when compared and focusing on our weight change, cabotegravir did have, again, some weight gain, but overall was found to be superior in efficacy to our daily oral PrEP options. And that weight gain is minimal. We really didn't have any rates of significant renal outcomes or any major complications with our patients with our long-acting cabotegravir injection. So we just want to reinforce that all these PrEP options might have some minor changes in patients in either their labs, their weight, some different things they might observe in our monitoring. But when it comes to the clinical implications of those, really all safe options for patients. So for monitoring, it is important that we want to really follow up with our patients, keep a close eye on these different complications, just to make sure that the patients are responding as we anticipate and addressing any changes that arise as those come up. But it's also, when selecting a PrEP option for a patient, it's important to go over what these different monitoring parameters will be. So starting with our oral PrEP, our follow-up is going to be every 3 months, and our testing is going to include an HIV antigen antibody combo test, as well as an HIV-1 RNA test. For our serum creatinine monitoring, this might vary based on age or risk factors and our baseline serum creatinine and estimated creatinine clearance, where we can monitor either every 6 months for patients that might be more high risk, or once a year for patients that are lower risk and we don't anticipate any changes in renal function. For our patients that are taking an emtricitabine and TAF regimen, we do want to recommend monitoring lipid panels every year and ongoing STI screening. For injectable PrEP, the patient is going to receive their testing with each injection. So at first, they're going to receive the HIV antigen antibody testing and HIV-1 RNA testing every month for the first 2 injections, and then every 2 months. We do not require any kind of serum creatinine monitoring for our injectable PrEP, similar recommendations for our STI testing. All right, so going back to our patient case, at this point, we have discussed PrEP options and safety data for each of our options with the patient, and he's completed a 28-day course of a dolutegravir-based regimen for PEP. We also wanted to share what monitoring parameters and frequency for those are available for our patients so they can make a decision when determining to pursue PrEP for the long term. And in this case, the patient wanted to pursue an option that had FTC and TAF to alleviate his concerns about the side effects. And he also had easily daily dosing when he was on his PEP regimen. He did express, though, that if he continues PrEP for the long term, that he would like to explore transitioning to long-acting cabotegravir injections because of the ease of just coming into for injections every 2 months. Another option we'd like to discuss with you that can help to provide our patients with having prevention as quickly as possible is called PEP-in-Pocket, or PIP. The PEP-in-Pocket was studied through interventions done in studies in Toronto, where patients were provided with a prescription for PEP before an exposure and instructed on when to initiate PEP if they believe they've had an exposure, and then instructed to follow up with the clinic within a week of that PEP initiation for testing and screening. So this would really be an option to really expedite that PEP treatment, again, for patients that might have that infrequent exposure, and we really want to get them with an option right away. What we found from this study was that 35 individuals initiated PEP, where 19 initiated PEP more than once throughout the study period, which did run from 2016 through 2022, so it was a pretty wide window. But during this study, there were no HIV seroconversions. So by providing the pill in pocket so that the patient could have that PEP started as quickly as possible, was able to help facilitate that care and then still maintain that an effective PEP option. It is important to note that participants in this study were involved in routine follow-up every 5 to 6 months for HIV and STI testing and screening. So this would be ideal for a patient that's already engaged in care and on good follow-up plan, but being able to empower them and provide other options for post-exposure prophylaxis. So really what we would like for you to take away from this program is that for men who have sex with men who may have infrequent risk for HIV transmission, we have plenty of different options for prevention, including both pre-exposure prophylaxis and post-exposure prophylaxis. We do want to provide ample education to our patients on the availability of PEP and the importance of initiating within 72 hours of the potential exposure, and to talk about different options such as the PEP-in-Pocket. But for any time we're discussing PEP for a patient, we also need to use it as an opportunity to discuss PrEP for future ongoing prevention. When talking with patients, we want to empower them to help make the decision for themselves and to take ownership of their health. So we would like to provide any kind of options for the different medications, routes of administration, dosing schedules, and involving all patient-specific factors when choosing and recommending a PEP and PrEP regimen, and allowing the patient to be involved in that shared decision-making process. And then always to counsel patients on any adverse effects and monitoring parameters that they would have. However, we also want to highlight that they are all relatively safe and that for concerns, we have options that have minimal side effects and risk for patients.
Thank you very much to Dr. Astle, and thank you to our listeners for joining in. To get more from our program, see the link in the show notes. You can view a foundational video module on PrEP persistence, more vlogs featuring specific case examples, clinical thought commentaries from people using PrEP, and downloadable PDF resources for healthcare professionals to print and share. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.